Good morning, Tal, and thank you so much for joining us today. I'm pleased to begin our next session, and we really hope for this to be an interactive and dynamic session to kick off today's program. Please allow me to introduce myself, and then I'll introduce our panelists in the series that they'll be presenting. I am the Assistant Director of Palliative Medicine at Scripps Health in San Diego. I lead our palliative services across the community health system, spanning 5 hospitals and clinics. In this role, I oversee our clinical quality, performance, and strategic priorities. I'm also a national expert at the intersection of palliative medicine and emergency medicine. And in this sense, I chair national committees, lecture widely, and love to educate clinicians daily at the bedside. Joining me today also is Ed Daniels, who has extensive experience in health information technology, including electronic health data exchange, interoperability, care management, and coordination. Ed has served as CEO, COO, and Vice President of various companies and agencies of several sizes in healthcare marketing, telecommunications, and emergency service industries. Most recently, Ed has been working on the formation of a new collaborative to streamline and digitize the electronic informed consent and advanced care planning process. And as if this weren't enough, for 14 years, Ed was also a volunteer firefighter and fire chief in the foothills of west of Denver, Colorado. We're pleased to also have Daniel Stein, who's president of Stewards of Change Institute, a not-for-profit think tank and advocacy and implementation organization. He is also co-principal investigator for the National Interoperability Collaborative, a new community of networks initiatives led by the Stewards and Academy Health. The mission of Stewards of Change, through advancing systemic information sharing, is to drive transformational change in health and human services at all levels of government, industry, and the not-for-profit sector. Daniel has over a decade of experience in being an interoperability thought leader, educator, and an advocate across the private and public sectors. And rounding us out today will be Mary Kratz, who serves as Executive Vice President of the Interoperability Institute, an affiliate organization in the Michigan Health Information Network Group. Mary is a leader in the field of biomedical informatics, working at the intersection of interoperability, telemedicine, and business development. So that certainly was a mouthful, and I am pleased that we have such a wonderful group of experts who will be able to share their perspectives on how exactly to frame today's issue. But if I may, I'll take just a few minutes today to provide, with humility, my frontline perspective as a clinician, seeing patients where the rubber meets the road. And that's, we're thinking exactly about the issue of where patients' wishes for care near their end of lives become known, and then how they are or are not followed. Speaking directly about the advanced care planning segment and electronic informed consent. I'll start by sharing a story of a patient, a young man who I took care of recently, Vietnamese with very advanced cancer. He had just been discharged from one of our hospitals, and after a series of discussions with our hospital palliative care team, had chosen for hospice. He had been home for less than a week when he had become weaker, and then for very important cultural reasons had not told his parents about how sick he was, nor the purpose of hospice for him. And so as he became more ill, they became more scared, and they brought him back to our emergency department. In those few moments when he hit our doors, he could not speak for himself, and he was in extremis. He did not arrive with a pulse, although we later learned that a pulse had been completed, but was just sitting at his bedside still. Without this defensibility to do less, our very skilled emergency physicians were prepared to default into the path of least resistance, which would be to have continued resuscitating him, putting him on a breathing machine, and various other measures into the intensive care unit. Fortunately, our palliative care team, one of the few in the country, is embedded directly into the emergency department. We were able to intervene, guide this family through what to expect, and bring this young man back home with hospice where, with greater comfort and dignity, he spent the remaining 36 hours of his life. And importantly, also stewarded his family through that process as well, so that they could be with him, rather distanced from him in our hospital, especially with visitation policy during COVID. So I share this story amongst so many others as an illustration that during these transitions of care, things can really unravel quickly, and even the best laid plans can become undone. Our team was there to intervene, but what would it have been like if we hadn't? And that's exactly the scenario that faces so many patients and clinicians daily across America. And afterwards, I think what I've seen is that we as clinicians tend to shrug, and patients and their families accommodate. They may not know that the care could have been different. They may forgive us for more than we deserve. And sometimes even they may swallow their bitterness at the events. When I first began my clinical practice, I used to ask, why? Why do patients who want one thing end up receiving something so very different at the end of their lives? And fortunately, over 2 decades of research, we now have a better sense of why this happens. We have more insight into this dilemma, and it certainly is a complex one. We've learned that indeed patients do think about their prognoses, even if they're scared to name it. We've learned that patients very much want to have conversations about their care at the end of their lives. And specifically, they want their clinicians, their doctors, to take the lead on this. At the same time, our research shows that clinicians don't very much want to have these conversations. We're often afraid of disappointing our patients, or worse yet, creating undue anxiety or fear or depression. We know now that that's not the truth. Actually, many patients and families feel more empowered after bringing these issues to the surface. For many clinicians, there's a sense of cognitive dissonance. We went to school and our training to be fixers. And somewhere along the way, we lost sense that we're healers and we can't fix all things. And part of healing means guiding our patients through difficult decisions and difficult realities. With that shift in thinking of our roles, there comes a huge cognitive dissonance as well. No conversation would be complete without mentioning how busy clinicians are, or at least the perception that we're busy. In the informatics literature, we know that even small interruptions or small asks of time feel like cardinal sins in the clinician's world. And we also know that clinicians can be disincentivized to take the time to have these conversations based on productivity measures or certain time measures, as the emergency departments are often beholden to. And lastly, we know that it's hard to document these conversations in a way that makes them easy to understand, readily interoperable with other health systems, or easy to find when the clinical care must be informed by decisions that happen in seconds, maybe perhaps minutes at most. And the reality of that is it sometimes may be easier for your documents to be known clear across the country than just down the street at a different hospital with a different EHR. So I used to ask why, but fortunately now, more recently, with how things have changed, I'm pleased to be asking how. How do we actually take what we know about the issues here and translate them into making a difference? We're at a great time in healthcare. We're seeing momentum coalesce around action. Patients are more aware of their rights and speaking up. The medical legal environment, for better or for worse, are keeping clinicians accountable for their decisions and care. And we have a new generation of healthcare providers who have new outlooks on health and are more whole person oriented, both for how they think about themselves and the care that they would like to give their patients. And of course, there's a sea change in interoperability and in health information exchanges, replete with health industry disruptors and regulatory bodies who are more poised to respond to this groundswell of interest. So to the panel today, before I give my time to them, I'd like to challenge them to think about these two things in the advanced care planning space and informed consent. The two important challenges of, on the one hand, creating these documents for patients' wishes and giving consent to their creation. How do we make it easy? How do we ensure that we're mindful of health literacy, of differences in language preference, of differences in cultural sensitivity around these issues, as well as the age divide and digital literacy as well? And how do we address things like the legal challenges of how these documents can be made, the specific requirements around notary and witnesses, which aren't as stringently applied in other industries and have become a great barrier in times of this pandemic, as we've seen. And then on the other hand, after we have these documents, how can we implement them, and how can we make it easy for clinicians to use them? Accessing documents once they're made within our electronic health records, educating our frontline provider staffs and incentivizing their use, and then how to really ensure that they can be readily used defensively in a nationwide network of fairly decentralized legal systems. We know that at the end of the day, technology cannot change clinical practice in a vacuum, but it can do wonders for putting us all at least on the same starting line. So with that, I'll say thank you all so much for gathering today to consider how best to put patients first. If not already, we all will be patients ourselves one day. And I know what kind of care I would want for my family, and I certainly wouldn't want less for any of you. So with that, I'll pass that on to Ed Daniels to carry us forward.
Thank you, Dr. Wang. And, it's always a challenge following Dr. Wang because he leaves me speechless, but yet I have to speak. So I will continue, but, thank you for that insight and just bringing this all home to the rest of us. Next slide, please. I also want to point out that all of us on this panel, Mary, Daniel, Dr. Wang, and myself, work together every day. We have conversations, so I think we're comfortable interacting with each other and with you, the audience. So please don't hesitate to put your thoughts and questions up, and we'll try to address them. If we don't address them within the context of this conversation today, we'll follow up with you. I'm pleased to tell you about our journey with the National eConsent Collaborative. This journey started really 2 years ago, so it really encompasses the time of COVID that we've all lived with. The Interoperability Institute, Mary Kratz especially, wanted to investigate the whole domain of electronic informed consent. And so my colleagues at Point of Care Partners, Pooja Babra and Michael Solomon, did an investigation and looked at the scope of eConsent activities that were occurring throughout the United States and Canada, a bit of other international intelligence gathering, but we learned a lot about what is happening in the entire eConsent field. And I should just take a second to talk about the scope of electronic informed consent, because I think it was perhaps best defined by the HL7 Standards Organization in the context of a FHIR consent resource. And it includes 4 major elements: privacy consent, which is the consent assured to share specific patient data. And I think Shreya Patel, who spoke before me, talked a little bit about that and what MyHan is doing in that area. It also includes informed consent for medical treatment. When you are having a medical procedure done, most of us have given our consent to perform that treatment, and to the extent possible, that can be done in an electronic manner. The third mechanism or element of informed consent is research consent, and that is where, again, many of us have consented to allow our data and personal health information to be shared for research purposes. And then finally, what Dr. Wang spoke so eloquently about, which is advanced care directive consent, and that is defining our wishes regarding our care when we're unable to speak for ourselves and how we want to do that. So the overall scope of the National eConsent Collaborative encompasses all of those elements, but we chose to initially focus on advanced care directives as an area that's clearly definable. It had a huge and has a huge importance, again, in this time of such high mortality and morbidity with the COVID epidemic. And so we took a particular focus on that, but not to the exclusion of those other elements, merely in priority order, because you can't do everything all at once. And so, back in February, many of you were part of our presentation. We conducted what we called an industry day, or an overall symposium on electronic informed consent, with a particular focus on advanced directives. And we were pleased to have some key speakers. That's actually where we met Dr. Wang and had the first opportunity to hear him speak. And again, I'm speaking just in the context of our panelists here. And we also had such luminaries as Dr. Rebecca Sidor and Linnell James from the Blue Cross Blue Shield Association, Anish Chopra, Mary and Tim Fletcher spoke. So a lot of the people that you'll hear from today, or that you all know about and are, proud residents of Michigan, spoke at that session, but we brought in a lot of additional experts also. And that was the opportunity to really kick off the National eConsent Collaborative. Since that time, we've been working with many different organizations, advanced directive vendors like AD Vault and Vinca, HIEs like MyHIN and others around the country, EHR vendors like Epic and Cerner, and Blue Cross Blue Shield plans and other insurance payers that have obviously a very keen interest in making sure that their members' wishes are respected in the overall care process. So as we've been working on this National eConsent Collaborative, we have evolved, and as Mary will speak here shortly, we have been talking with the Interop community of practice, and that organization, again, as Mary will elaborate, provides a sandbox, an opportunity to test various types of systems, workflows, API interfaces, and has a reserve of synthetic data so that this can be done without the encumbrance of dealing with actual personal health information, which has to be protected. Much easier to test in that environment. So I'm pleased to announce that the National eConsent Collaborative is applying to become an emerging community of practice within the Interop community. And I think that this will give us a much stronger toolkit and opportunity, not only in the technology side of things, but also in terms of governance and structure that will allow us to go forward and focus on our mission. Next slide, please. So as a part of the National eConsent Collaborative and us hopefully going forward as a community of practice, we will stand up several work groups, and I won't dive into all the details on this, but we plan to work very closely with the HL7 standards organizations. There are a number of accelerators, which are special interest work groups that are focusing on certain topic areas like PASIO and patient empowerment, et cetera. These work groups are underway in developing these FHIR and HL7 standards, and we plan to support them and enhance their efforts and contribute to their efforts, but not try to duplicate their efforts. Also, we are working with the BPM Plus. BPM stands for Business Practice Management, and we are working with that organization, which is a part of the OMG, Object Management Group Standards Organization, to help develop shareable workflows to help manage these processes. And, fortunately, we were able to develop one of these for advanced directives, and I'll talk a little bit about that in the next slide or two. as an interop community of practice, as I mentioned, we'll be having access to the MELD sandbox, which Mary will speak about, and we'll be able to exercise a lot of the things that our experts are able to draw together and cooperate with the various vendors that are working in this arena. But also, as Dr. Wang mentioned, a key both obstacle and feature of the landscape are the laws, policies, regulations that are so varied across the United States. Each state has a different set of laws that dictate how advanced directives work and how informed consent works. And also, many states have their own laws regarding the privacy of personal health information. So one unique thing that we plan to do is that to survey and provide ongoing surveillance of the laws and regulations that will impact this technology, because you might be able to share a particular advanced directive in one state, but in another state there has to be an in-person notarization of that directive, so that makes it more challenging to make that an electronic process. So that'll be part of the scope of what we do. Next slide, please. So this and the next slide are depictions of the workflow that is related to advanced directives and identifies the specific electronic consent elements of advanced directives. I'm clearly not going to get into each one of these slides and dive into the detail, but I wanted to explain to you that there are numerous detailed elements of the overall process of both engaging with the consumer and educating them about advanced directives and consent. Then there's the legal and technical step of actually creating documents that define that person's consent and what it is that they are agreeing to. Next slide, please. And then when that information is needed, whether it's the generalized consent information or advanced directives, and there's no way that I can be as clear about that as Dr. Wang was explaining the case that of the patient that he was taking care of in the emergency department. But when a patient presents, whether it's simply in an outpatient setting or in other types of environments, those documents and the patient's wishes need to be made known. And this is a whole complex process in itself. And then after the treatment episode is over, there's the opportunity to follow up and adjust those directives based on the experience that the patient had and the providers had. So this is a complex workflow. We did, again, as a part of the National eConsent Collaborative, work with our colleagues at BPM Plus to model this out in the form of a standard compliant workflow, and we'll be pursuing this effort as we have the opportunity to work in the MELD sandbox and be able to plug in our various vendor partners to this whole process. So that's my summary of the National eConsent Collaborative and our hopeful joining with the interop community. And the next speaker, I'm just going to take a quick note to mention that we've really been talking about the healthcare world here. Dr. Wang, obviously practicing physician, myself, and talking about advanced directives, but there's a much broader scope to electronic informed consent that moves into other areas, including health and human services, education, the judicial system, etc. And so our next speaker, Daniel Stein, will address that, and I will turn it over to him. Thank you.
Thanks, Ed. Great intro for what I'm going to just speak about for a few minutes here. So again, I'm Daniel Stein, I'm the president and one of the co-founders of Stewards of Change Institute. We're a 501c3. Can you advance the slide? Great. And so I'm here to chat with you about I need to get another slide up here. There you go. Thanks. So as Ed said, the question ahead of us is that there are many other areas that are important for consent, especially as we think about whole person care. And so our work has been focused on integrating social factors into healthcare through a couple of different approaches, and I'm going to just touch on those as we proceed here. So if you could advance, that would be great. And so the structure of our organization is, as I said, Stewards of Change. We've been around since 2005. We've been focused on connecting across multiple disciplines, from originally from social services and child welfare, through healthcare, public health, education, justice, those kinds of things. And then about 4 years ago, I'm seeing the chat, but I can't increase my volume. I don't know if folks can hear me or not. I thought we had good volume there before. So I'll just speak a little louder. We were able to create, with support from the Kresge Foundation, something called the National Interoperability Collaborative, yet another collaborative. But this one is really focused on creating a community of networks, recognizing that each of the different domains really has different aspects to contribute to whole person care, and that we need to be considerate of those particulars, whether or not it's healthcare, justice, education, those kinds of things. And so we have been building this national collaborative. There are multiple thousands of people who have joined over the years to really contribute their thinking and their subject matter expertise to creating a complete picture. So along the way, and actually prior to the creation of the National Interoperability Collaborative, we got to know folks at MyHIN through work we were doing on a national level. And so have really begun that journey together with MyHIN over the years, and are looking at ways to be able to bring our expertise and network together with those of MyHIN and Interoperability Institute. Next, please. About a year and a half ago or two, within the NIC, we created a project called Project Unify, and the purpose of that was to go beyond simply identifying the issues that were related to data interoperability, data sharing, and ultimately coordinated care. And what emerged from that is this idea of Project Unify, which is to bring together the various, or at least to articulate the need to bring together the various domains. And as you can see on the graphic, this in a way illustrates the kinds of things we're attempting to do with putting the individual or family in the center of the service consortium. We can clearly see that there are absolutely different elements that are contributing to that person or that family or that community's well-being. And so the only thing, let me just pause for a second. Apparently there's some volume issues here. I can't turn my volume up any higher, but I can try to change. Let me just check to see if a different speaker is better. Is that any better? If you can just send me a text. Yes. Okay. So there you go. Just pick a different speaker if you don't like the first one. Thanks. So so this graphic is, we offer this up as a way for folks to really see where you are contributing to the overall health and well-being of individuals, and whether or not you're working in the healthcare space or the behavioral health or human services. There are different state systems, local systems, different care providers, and all of those need care coordination and integration and ultimately data exchange. And our goal is to really frame that out and to create really a roadmap or a blueprint so that organizations can effectively achieve that, recognizing it's a long-term journey, and it's complicated, to say the least. Well, as part of this, one of the things that really stood out over and became more and more clear over the years has been the obviously many of the challenges and inhibitors to being able to accomplish this work. Looks great on paper. It looks like we can just go do it, but in fact, the legal framework in which we operate, in which each of these domains operates, has its own unique laws, rules, policy, statutes, and implementation processes. And so consent, or informed consent, really emerged over the last year as we were working on Unify as one thing that, if it could be fixed, so to speak, or improved marginally, could actually contribute in an enormous way to the overall vision of Unify, and more broadly of a holistic approach. Unfortunately, or maybe fortunately, depending on how you view it, almost all of the work has been happening in the healthcare space for all sorts of good reasons, and health has been leading the charge. That being said, there is a larger universe beyond health, and that's what we're trying to bring to the table and bring to the conversation. So next slide, please. And one more. So as we think about actually integrating healthcare and the social factors, we began working with a couple of the federally supported integrated care for kids sites. It's a program out of the Centers for Medicaid and Medicare Innovation, started about 1.5 years ago. Really a brilliant program that has at its core the goal of connecting Medicaid, behavioral health, children's services, education, food, courts, with the express intent of keeping families together and eliminating the removal of children from their home, especially when there's substance use disorder. Now, I mention this because there are 8 sites across the country that are funded for 7 years. So there's enough runway to actually do something, which is great. Oftentimes, proof of concepts or demonstrations last 1 year or 2, and just get going when they actually have to be sort of re-upped. Here, Inc. is something that actually has enough runway to be able to do something, and they're implementing. So the best news here is all of the work that's going on is wonderful, but without actually being able to implement it, it's still a concept. And so within the Inc. universe, there are several sites that are part of our National Interoperability Collaborative and part of this larger work that Ed and Dr. Wang expressed. And so we'll be talking more about that. But the reason I'm showing this is that there is an avenue and a route to actually testing out some of these concepts. And we intend to start small, but move quickly forward on that. So next slide, please. And so as we began looking at this problem, what became clear, and you can read that as well, is that the case for developing a secure, cross-domain, replicable consent model is imperative, because today there are none. And without a common consent utility, everybody is required to figure it out themselves, and it limits their ability to share information. So much like our health and human services infrastructure, safety net is fragmented, and we unfortunately end up recreating the wheel too many times and reinventing stuff that works or continuing to do things that don't work. And so what we're proposing here is this idea of a service utility, something that in fact could be replicated on a community by community basis, recognizing that in fact there are unique components of every community: technology, infrastructure, and of course the state laws and other processes. So what we're proposing is a concept of service utility in order to be able to provide a foundation upon which communities can actually build out what we're explicitly calling a replicable model. So be able to use the basic underlying infrastructure, and in fact and being able to customize that for the local requirements, not necessarily looking to build a national model, because the variability both between the legal aspects, the technological aspects, and the practices that are happening there. So so this idea of a consent is a pretty big idea, and that's what we are continuing to proceed. So I've just got a few more slides I want to share on that. So if you could go to the next one, that would be great. Our goals are to make the appropriate information accessible electronically, regardless whether or not it's coming from a health or human services environment. That's the goal. Next, please. And our objectives are to really to increase data exchange, to improve equity, most and foremost importantly, care coordination, outcomes, and operational processes. We want to empower individuals to provide or revoke their consents with a modern application. And we want to be able to resolve legal hurdles for data sharing so that those things can be learned. And of course, we want to build on progress that has happened. I don't mean to leave the impression that there's not been work. There's certainly been tremendous work within ONC and CMS and Administration for Children and Families and industry, but in order to create this thing, but we need to build on the foundation that's been laid so far. Next slide, please. And so what we are doing is, as I said, developing this with the intention of being able to implement this within the integrated care for kids sites, either in New Jersey or New York. Next slide. And you can just continue to animate this to the bottom here. So we're currently right in the midst of finishing up a national consent scan of best practices or promising practices supported by Robert Wood Johnson Foundation. And the purpose here is to really look at what is happening out there. There is no compendium today of the various consent practices, so that again we don't recreate stuff that has already happened. And we are basically at the final stages of editing this. That it'll become available, and we'll make it broadly available to the larger community out there. We're currently creating the requirements and the blueprints for implementation of a proof of concept. We are working within the Project Unify and with other partners like Mayan and Interoperability Institute and eConsent to actually create working groups or build on working groups with subject matter experts to really provide a comprehensive view. And of course, like all projects, seeking resources to sustain the work and to continue to move it forward, so we can actually publish roadmaps and blueprints in as much of an open source, open standard way as possible. Next. So the just very briefly, the consents, the scan is really focusing in on 5 categories of promising practices, including what's happening with electronic health records and the healthcare space itself, and point of care partners, and Mayan has contributed a lot to that. But we're also looking at community information referral systems, community information exchanges, health information exchanges, and of course, industry and government initiatives, like stuff that's coming out of the ONC. So combined, those things really represent, I think, most of the universe of what's happening in consent. Next, please. Our partners in developing this are wide and varied, and you can see from this slide, and there's some others that have joined recently. We have an open community for those of folks who want to monitor, audit, or participate. We welcome your participation in that. And it has definitely been a collaborative effort as we have been moving forward, which has been really exciting. Next. Along those same lines, we have been working hard to bring in various other efforts and initiatives. There's a sort of an acronym soup up here, and there's a prize if you get them all. But reaching out to those organizations and initiatives that are looking at various components of this, again, to see as best as we can to incorporate those voices and the lessons learned and the promising practice. So again, we have a compendium. We don't have necessarily to start from scratch. And if you go to, I believe, the last slide here, we'll just wrap up. And so again, just thank you for the opportunity to share that. We're excited about trying to bring this work together with the work of consent in the healthcare world, and recognize that it's a long journey on that. Doing it together is probably the most productive route we can do, so we don't leave anyone behind, and we recognize the challenges that we're facing in both education and justice and housing and other places like that. With that, let me turn it over to Mary. Thanks so much.
Very good. Well, thank you, Daniel, and to all of our panelists. So we're going to take a small pivot. It's been delightful working with the National eConsent Collaborative and Stewards of Change Project Unify. But we're going to take a pivot and talk about some of the technology that Interoperability Institute has been providing in a new activity called the Interop Community. Next slide, please. Interop Community is an emerging collaboration with the mission to advance healthcare interoperability using open platforms and open source software. Interoperability Institute is providing stewardship and is joined in the Interop community with Red Hat, providing us guidance around standing up a true open source community from lessons learned and guidebooks that are available for both the community person aspect and also the technology management components. Also integrating the healthcare enterprise for the USA, IHE USA is attached to HIMSS and provides both data toolkits and also a number of events that provide learning to the industry, and also those hands-on technology activities where we can look didactically at different aspects of interoperability. The executive director from the Object Management Group's Business Process Modeling for Health. Many other industries have completed and standardized on those computable objects. And that is accomplished by standardizing on your business processes. And there are tools that make it available to actually create models for how we would architect a system or a service. And so very excited about some of the electronic consent business process modeling that Ed shared with us. And then finally, Interopion, that is a technology company, provides an interoperability platform and also a private sandbox environment. Next slide, please. So one of the very first activities of the Interop community is we stood up an open source sandbox environment for healthcare. Sandbox, playground, gymnasium, what this is a technical environment where on a cloud-based platform, this is hosted on Amazon Web Services, we've spun up a dozen fire servers, HL7 fire servers, that emulate a healthcare environment, and specifically a health information exchange. So those fire servers represent provider organizations, payer organizations, lab, pharmacy, etc. This sandbox environment is called MELD. It is not an acronym that stands for anything in particular. MELD is meant to be a melting pot. The open source code development, as I mentioned previously, is based on FHIR. You can see some of the various versions for the HL7 standard there for those FHIR resources. And it provides us with the ability in a safe environment to create, edit, delete, or import data. So we preload this sandbox environment with synthetic data that represents a variety of use cases, particularly for electronic consent, a lot of focus on the healthcare side in standing up advanced care plans, But in addition, Interoperability Institute has been working with Project Unify and the Stewards of Change in providing the sandbox environment for those activities with integrating care for kids and providing interoperability between health and human services. Next slide, please. So there are many, many benefits of bringing to the industry a standardized sandbox environment. First of all, is we bring together community through an open source model. Many hands create light work. Right now, we're processing a number of membership petitions, including the National eConsent Collaborative, to bring together communities of practice, to utilize resources, to do proof of concept around some of the industry's most daunting challenges. We can rapidly expand functionality and innovation as we bring the community together in that technical sandbox environment. We've been engaging with a number of standards organizations. I already mentioned the OMG's BPM Plus for business process modeling, but we also participate and bring the MELD sandbox to the HL7 Connectathons. Having participated in 6 different tracks, we participated in the CMS Connectathon event, and just yesterday, the Global Digital Health Partnership held an event, and MELD was the underlying sandbox for testing interoperability between a host of US participants, New Zealand and Netherlands. So exciting to see that acceleration by utilizing these environments. As I mentioned previously, we have the ability to import and export synthetic data that we refer to as data packs. A data pack is a package of synthetic data that is specifically created for a use case. And then it provides us with this future ability to be able to interconnect sandboxes. So MELD has an import-export function. For example, in a lot of the Connectathon activities, we don't see a lot of participation by the electronic health record vendors for their sandbox environments and sharing the exchange within those Connectathon events. They have their own sandboxes, but they don't have an interface to be able to expose their sandbox to an open source sandbox such as MELD. So we built that little piece of functionality to be able to really enable interoperability testing across the industry. Next slide, please. So the notion of a proving ground for open source software, I've talked about MELD and the sandbox environment, that has a specific code base. In the MELD sandbox, that code base is curated by technical engineers who provide best of breed through an open source model. But the next piece is, what do you do about that? And so what you do with that sandbox environment is create an open proving ground or a sandbox. And this is what we endeavor to do with the community of practice for electronic consent, so that we can simulate different scenarios for advanced care planning, for informed consent, for privacy consent, for the emerging artificial intelligence activities that are coming from the research community. We can also use this environment as a training environment for public events to be able to train on new standards, such as the HL7 fire standards and how we define fire resource bundles for electronic consent. It gives us the ability to validate. Embedded in MELD is the Inferno product from ONC to be able to validate the HL7 fire standard and other activities. Next slide, please. So MELD provides an open proving ground. This is a free sandbox open to the world and to the industry. It's populated with synthetic fire data. And I won't reiterate, but you can see the list of all of the various activities that are underway on the MELD Sandbox with the health industry and with various communities of practice, including electronic consent. Next slide, please. So I just wanted to mention very briefly, in addition to the MELD Sandbox, which is an open environment, many organizations learn, participate in those open consensus-based standards such as BPM Plus or HL7. There's a variety of standards in the healthcare industry. But organizations also want the notion of a private proving ground, or what we refer to as a locker. A locker is a private sandbox instance. And the notion is that you can take a certified locker that has that MELD open source code that a community is working on, and you can actually instantiate a hosted instance of a private locker for your specific business needs and for your organization. As it implies, that locker, the owner of it holds the key and controls who has access to that environment. So these private lockers are used for organizations to internally educate their personnel. They're used for specific project activities. A lot of really, really interesting dialogue with many of the big national systems integrators who spin up these private sandbox environments to provide proof of concept to public sector funders. So lots of interesting activities there. Interoperability Institute has a product that is a private locker that is interoperability land. And so that is available to any organizations who want to quickly spin up one of these sandbox instances for their own internal business purposes. My technical team tells me that it takes 8 minutes to spin up a private environment hosted on our AWS cloud platform. So you can do the math in your head for your organization of how much the time factor would be versus just spinning up a turnkey solution. Next slide, please. So Ed talked a little bit about the National eConsent Collaborative, putting forward a membership petition to become a community of practice. I believe we're all familiar with communities of practice within the interop community. It is a group of people with a shared concern or passion in coming together to look at domain relevance, specifically here interoperability, both within healthcare aspects of eConsent, but also the human services aspects. Coming together as a community to reflect on this isn't just a technology, a policy, legal, regulatory. There are many, many aspects that come together. And then being able to utilize these sandbox instances, either publicly or privately, to bring into practice solutions for electronic consent. Next slide, please. So communities of practice both add to the MELD open source code base as appropriate. Many communities of practice may have a technology component, and this MELD Sandbox may not meet a specific functionality that a particular community of practice requires. Next slide. But primarily, community of practices use the MELD open proving grounds or commission a new proving ground under a specific project. For example, for Project Unify, the MELD Sandbox is a resource that's available to that community to stand up a proving ground for interoperability for aspects of electronic consent between health and human services. Next slide, please. So finally, the work of the eConsent community of practice is to sponsor electronic consent business process modeling, to sponsor the creation of the synthetic data that we commonly refer to as data packs or personas. So that data that is packaged up to represent a person's journey through the electronic consent process and to enable a proof of concept. Next. So I want to thank my fellow panelists, Dr. Wang, for kicking us off with just his passion around the importance of interoperability in all aspects of consent. Ed Daniels for sharing it with us that patient journey and the activities of the National eConsent Collaborative. Daniel Stein for Project Unify and the activities of Stewards of Change. I will open it up to any questions from the audience for any of the panelists. I see a question that, yes, I do believe the slides will be made available.
And I see a question posted about that patients are taking more of an active stake and making sure their wishes are known and asking that their wishes are followed. I think there are many advantages to that. I think there's an obscurity. Sometimes I call it a conspiracy of silence that happens for the care of patients in which the science is not necessarily well known, and it creates prognostic murkiness, and patients end up getting defaulted into certain care pathways. And so I'm a proponent of taking the realm of what can be known and as transparently as possible, helping patients have informed consent, electronic or not, in the decision-making process. Does that shift how we provide resources? I think it shifts a lot of things. I think it takes some amount of autonomy and agency away from healthcare delivery institutions and individuals, and it does put more onus on patients to make known what their broad-reaching goals are. So that dialogue at the point of care does shift less out of the fundamentals of, do we do interventions A, B, or C, and more, you hope to arrive at outcome 1, you may settle for outcome 2. Okay, in the litany of things that we have to offer and plan for, how much closer do we get you to 1 or 2, rather than dwelling in kind of the base layer of that decision making. And then the last part of that question is the notice of privacy practices and fact sheets. I'll turn to my co-panelists if there's something that they may better speak to in that sense. I think regardless of how we codify wishes or memorialize them, I think a huge piece of this must be in how we have the conversation. And so to the extent that patient decision assistance tools should be focused upon, I think that's a big piece of this puzzle.
I think that, all of us need to be better educated in working with patients and their families and the community to help them understand this new world where they have more of a say in consent down to the granular level, and empowering them is, like you said, Dr. Wang, I think a challenge and additional responsibility for the patient and their family members, yet it's one that I think we all agree is a move forward. So I think educating and all of us participating and learning more about this is an important element of this.
It looks like there may be a question about Sandbox availability.
So the MELD Sandbox is available. You can go to interop.community or meld.interop.community. The MELD link will take you directly into a request. You set up your user account and it is available now. There's also a link for info if you're interested in a private sandbox. You can send a message that'll get you in touch with the right folks. And that private sandbox is available on the AWS Marketplace as well. And just search on Interoperability Land.
All right. Thank you all so much for your insight on that multidisciplinary panel. I think it was really interesting to get a variety of perspectives on the eConsent project, just because I know that sometimes we can be really focused just on the technical and legal, and obviously there are a lot of other things that come into play. So thank you all for your participation, and please feel free to stick around if you'd like to see what we're going to be talking about next.
Thank you.
Thank you for the opportunity.
Thank you, Shreya. Appreciate the opportunity to share.